It's great to be here at the Connected Health conference, and I came in and I feel like everything's connected in healthcare, and there's so much information that's sort of flowing about. It makes me very happy. I know, however, I'm going to go out of here, and when I go back out into my regular job, I'm going to find that things really aren't that well connected. And kind of what I'm talking about today is sort of as a big company, how we're sort of seeing connected health and what we're trying to do, and what we see as both the opportunities and also the various problems that we have right now in terms of connecting to people. So I have a relatively clunky looking presentation here. I'm a little ashamed following Carl, because his was so beautiful. And we also have a pretty clunky headquarters down in Woonsocket, Rhode Island. I understand they have a very beautiful headquarters in Verona, Wisconsin. So something's wrong, because we're a big company. We're the biggest company in healthcare, market cap, number of employees, revenues, but that, from your point of view, just means that we're sort of big and lumbering, and we're trying to sort of understand the connected environment. But we have some specific things that we want to do in that connected environment, and I'll click through this. This is basically sort of the metaphor about the pharmacies in the past, and I think all we're trying to sort of establish here is that we do have some real ambitions in terms of things that we can do in the pharmacy. Our big assets are really that we have about 7,500 retail locations, and we're moving that in the direction of 9,000. And we have about 75 million people for whom we provide the pharmacy benefit management. So we touch a whole lot of people, and we can touch them both electronically in terms of the people who we have in the PBM, and we have literally millions of people coming through our stores on an everyday basis and interacting with our pharmacists. But if we want to do more from the point of view of things at a pharmacy, or we also operate the largest chain of retail clinics called Minute Clinic, and we want them to do more, they need to be connected in to the rest of healthcare. And so we're basically out there searching for what is the best way to get connected on a big picture basis, our entire enterprise somewhere else. Now, we're big in lumbering, but on the other hand, pharmacy is an area that's been very fast in terms of moving data. You know, long before any medical claims got electronic, all of our claims were electronic. They auto-adjudicate in real time, and we get a lot better data, a lot faster than anybody else in the healthcare system. But that's not saying much. It might be like having the highest SATs in the NFL. So when we look at the sort of how are we going to connect up, what we see is that, you know, there's increasing concentration in the electronic medical record area, and there's some key competitors, and you all know who they are. Obviously, Carl and Epic are a big player there. But then, in addition to the EMRs, there's a variety of different places where we could go to get connectivity, and we're kind of like trying to understand that. One place for us is SureScripts, because SureScripts is basically connected to every EMR, so that the EMR can do e-prescribing into our pharmacies. All the pharmacies are linked to SureScripts. SureScripts is linked up to all the EMRs. So there's a pipe there, and that's how I think about things. I used to understand electrons a little better than I do now, but talk about pipes. But there's other series of pipes out there. So these bidirectional flow vendors, Relay, Medicity, and Siemens, all have plays in that direction. And then there's HIE developers, DB Motion, Relay, Axolotl, Medicity, you might consider there. Then there's the clearing houses, Navinet, Availity, good examples of places where physicians' offices are going to do business on the web, basically. There's new collaborations amongst the EMR vendors. Commonwealth's the best example of that. And then there's a whole series of health plans who are developing their own neural networks, is what I call them. You know, good examples of those would be the PCMH program in Maryland that Care First, the big Blue Cross plan down there, does for iCentric, or in Hawaii, HMSA, the Blue Cross vendor there, is Coziva. So there's a lot of different places where one could go to try to get connectivity, and obviously meaningful use too is driving people much more quickly, especially the EMRs, in the direction of connectivity. I would say 2 years ago I sort of looked at the EMRs. They were all built sort of internally and they didn't want anybody else coming in, but increasingly through Meaningful Use 2, they have to allow people like us in, and we need to be able to get in. So I'll give you an example of sort of how we're doing things now, but I don't think it's a great example. It's sort of what we're doing now, and maybe we extend that, or maybe we find a better way to do things. But I'll take the retail clinics. So our retail clinics are called Minute Clinics. We actually have about 800 of those clinics now, and we're in the, as we've told Wall Street, we're building either 3.5 or 4 new Minute Clinics a week for the next 3 or 4 years. So we're very bullish on the development of retail clinics. People need care, and we think we can provide it in a good fashion. But we need to have those Minute Clinic providers hooked up to the rest of the providers in the healthcare space, or at least other primary care doctors or primary care medical homes with whom we can share patients. And so that's the big effort that's underway right now. Well, SureScripts has a company they bought called Cryptique, which actually allows us to move data fairly well. Not just pharmacy data on pharmacy transactions, which is what's happening traditionally in SureScripts, but what we have to do with this is basically it's an arduous process, and that's why I love to see the things in the back of the room here and the presentations today, because everything looks, you know, relatively sort of seamless and well lubricated, and it happens, you know, basically with the speed of light. Whereas what we find is we have to go to each of our affiliates. We now have about 35 ACOs or integrated delivery systems with whom we're affiliated. We go to each of them, and each of them want their information in a different way, and their IT teams have big agendas that they have and a lot on their plate that they have to be working on. And so can they work with us? And everybody's got a different interpretation about sort of what patient privacy means. And so the pace is relatively slow, even though we can move. We have the pipes built, and we have the ability to sort of take our information and get it over to them. So the question for us is really sort of what's the best pathway? Let me give you a sense a little bit about kind of what we're doing and why this connectivity is so important to us. So this is the patient affiliated healthcare system in Minute Clinic, and you can see that's our Minute Clinic record down in the, on the side there. So we have a homegrown electronic medical record, probably is past due to replace that with something that's more or less off the shelf. But it does a good job for us right now. Now, what we want to do is when the patient presents at Minute Clinic, this presentation is all electronic. So there's basically a kiosk. There's nobody there but the nurse practitioner. So there's nobody sort of helping. Patient checks him or herself in and then sees the practitioner at Minute Clinic. And we go ahead and access our electronic medical record. And then what we want to do is link into the health system where this patient is a primary care patient to grab information that's really important to us, like allergies and present list of medications and things like that. Now, if that patient happens to be a Caremark member, Caremark's our pharmacy benefit management, one of the 75 million people that are in Caremark, we have the sort of moment of truth about what medications they're on, much better than when we would get out of the electronic medical record, because we know what's adjudicated. And we're basically developing a whole series of messages based on clinical algorithms that we can do ourselves that will be going to Minute Clinic. So if you're a Caremark member, come into Minute Clinic. We'll address your adherence issues. We'll talk to you about gaps in care. We'll make sure that you have your vaccinations and things like that. But for a lot of patients, we either want to plug them into the healthcare system, because only about half the patients we see can have a primary care provider or can name their primary care provider, or we want to be sharing care with the primary care provider, so we need to get into their EMR. But with the current approach that we have right now, we can see the patient and then actually transmit that information electronically to the electronic medical record if we've gone through this process of saying, okay, let's get together. We both are on SureScripts. We'll use Cryptique. We engage with their IT team, and we can accomplish connectivity. So let me give you a little sense about what that looks like. So this is sort of what our electronic medical record looks like, and this is the patient, and we're just basically sort of picking up information from the electronic medical record of the affiliate that we have. So it's good in that regard, and it means that we can become sort of a virtual member of their primary care medical home, as it were. And obviously, this is going to improve quality and also let the doctor know sort of exactly what happens. The good thing about this process is that as we integrate with the health system record, I can show you on the next one, it doesn't show up very well, our information through this critique SureScripts approach actually travels into their EMR, and it's not an outbox. That's the other thing that you see when you start talking about EMRs. Oh yeah, we're connected, but you're connecting into some outbox that the provider's never going to go into. So increasingly, for example, we do point of care testing, laboratory testing. So that information has to go not into an outbox, but it has to go into the repository of laboratory information. And our note has to go into the list. This is what this particular slide shows. Our note has to go into where the physician is looking at notes so that they can review sort of what happened. Just as if you're a primary care physician and you send somebody to a doctor in your system and they've had a cardiology note, we want our note to be in there. So this is available. So we're connected, and in 4 or 5 places, Cleveland Clinic, Allina are good examples. We have this sort of complete connectivity, and then it creates the ability for us to be providing more care that we can share with people. But as I said, it's a very arduous process for us to accomplish this, and it doesn't feel at all like the sort of easy connectivity that's sort of the theme here. And the question is sort of what is going to sort of win out when we think about things? Well, we're thinking about sort of what the alternative methods for connectivity are, and I'm sure, although there aren't others exactly in our situation, there are a lot of the rest of the people in hospitals and elsewhere thinking about how are we going to accomplish connectivity. Well, one thing you could do is choose a highly prevalent EMR. So I've got Epic or Cerner here, but I could be thinking about Allscripts or Athena as they grow, or eClinicalWorks. You know, all of them are going to have a relatively large series of providers with whom they're connected. So will connectivity be easier if you've got sort of a shared EMR? That's still not going to help much because nobody's going to get to sort of a 25% share soon, and that's basically leaving out 75%. The second place where you'd look would be to the HIEs and watch the sort of health information exchanges over the course of the last 10 or 15 years. And I would say the honest assessment is that in some places, Indiana is the best example that I can think of. Some other places as well, maybe Delaware. The HIEs are sort of up and running, and there's information that's traveling through them. But by and large, you can't make a 50-state bet on HIEs today. And it's unclear how quickly these things move. I'm always thinking about IT the way I think about genetics. And when I worked at Aetna, I had a medical director who was in charge of genetics, and she had this great slide that sort of showed 7 different Time magazine covers over an 18-year period of time, each of which said the genetic revolution is here. You know, well, except if you're taking care of patients with non-small cell lung cancer, maybe myeloma, you know, the genetics revolution hasn't really arrived yet, and I'm worried that before I retire, the HIE revolution is not going to be here. So what about the EMRs sort of opening up their architecture more? They could do that, and it looks like when you see the kinds of things people are doing intra-company right now, it seems that inter-company they could do the same things if they were willing to open things up. So we're watching the Commonwealth Alliance. It's basically a group of 5 or 6 major EMR vendors who have decided that they're going to open up their architecture and allow much more data exchange. If you don't do those things, if you sort of run out there, then basically you're thinking, do you look for one of these bidirectional workflow or HIE connectors to evolve? They're linking up disparate parts of integrated delivery systems right now. So if you talk to Relay or Medicity, they're doing that. And Relay, obviously, we've had a long relationship with them because they make our switching model that allows us to auto-adjudicate claims. So we know them. But the question is, are they going to be sort of serious alternatives? They're relatively small companies, and a lot of these companies are being bought by larger companies. And when you work at a large company, you have to be very careful about what we do with a small company when you buy it. So, you know, this is what gives me pause right now. You know, I think we have to put some bets on the table, but it's really not clear in a way that one would not expect, given sort of what you hear at a conference like this, how tenuous it is or how much of a gamble it seems like in terms of deciding exactly kind of how you're going to go about connectivity. And there's no sense in trying to play all these different avenues. That's really not going to work. So big lumbering company like us, we have difficulty trying to decide exactly how to do this, but we know that we need to do it. I'm just saddened that, it hasn't seemed to sort of move faster. Now, one place where we do find it moving relatively quickly is with regard to these neural networks. And it's not clunky, but, it's not, the most exciting thing in the world either. It's basically the Blue Cross plan setting up a website, a nicely articulated website that's also got a lot of quantitative analysis going on underneath it and claims data being processed and dumped into it. And as a result of that, ability to sort of measure performance overall on basic pay-for-quality measures. So take, for example, Care First, which is, as I said, the Blue Cross program in Maryland. They've tried to link up, and they've got about 2,400 doctors participating in the primary care medical home. And what they're moving in the direction of is getting the doctors to worry about total cost of care. But on the way there, they have a series of quality, pay-for-quality measures in place. And so the doctors are on these systems all the time. It's a little more advanced even, I would say, in Hawaii on COZIVA. And what you see is the doctor's office has hired somebody who comes in and basically monitors the COZIVA program. Now, that's not rocket science at all, and they don't have any sort of fancy slides about it, but they do have the doctor's attention and the doctor's office attention, and they are moving the needle on these pay-for-quality measures. So what we're trying to do is figure out how can we get our specific opportunities into them, because as I said, we're analyzing data, and we happen to be the PBM for both Care First and for HMSA. It's why I know them so well. But we're analyzing data on all their members and looking for places where you can intervene, identifying somebody who's diabetic, who's not on an ACE inhibitor or an ARB, and suggesting they should be on one, finding people who have diabetes, who are hyperlipidemic, and nobody's done anything about that. As we collect more laboratory data and have full set of pharmacy data, these algorithms get very thick as well. So a major healthcare problem is adherence, and nobody takes their medications, or at least half the people don't take their medications when they are recommended medications by their doctor or they leave the hospital. So we can message all of those things, and increasingly what we're doing is putting our messaging in place for them. So this gives an example of Hawaii. These are the measures that we're doing out in Hawaii. These are our pharmacies in Hawaii and our planned minute clinics for Hawaii. But you can see the kinds of things that we're interested in here. But more importantly, I think, is that we can actually provide them. They have relatively slick-looking systems, and we can provide them with information that they can then plug in to their overall system and get what we want messaged into COZIVA. So this part of connectivity is looking pretty exciting. There's something that's sort of low-tech feeling about it. But as long as we can provide doctors with information that basically says, here's how you compare with regard to adherence against other doctors, and here are the patients who are the opportunity, then we feel like we're really going to be able to sort of accomplish something from the point of view of getting patients to take their medication. So there's a lot of good outreach that you can do there. So that's a part that, I would say is not the slickest part of connectivity, but is a good example of sort of how connectivity is occurring. And then we're also trying to take that information in, so what we call inbox, basically them sending information to us. What does the insurance company or the integrated delivery system or the ACO want us to do? It's a statistic that United Healthcare put together, but I like it. They say that 75 to 80% of all of your interactions with the healthcare system are with the pharmacist. So what we're doing is basically taking this kind of information in and arming the pharmacist with it, so the pharmacist can have relatively quick and directed conversations with individuals when they come to pick up their medications. So that's that kind of connectivity is in place now. We control more of that, but that's what makes connectivity easy, when you have complete control over it. But we have to reach into the insurance company to have them provide these messages for us, or to the ACO. So I'd say the last thing that I would mention is that we're very bullish on telemedicine. We've actually put telemedicine up now in several of our pharmacies in California, where we're basically going to busy clinics, busy retail clinics, and if somebody doesn't want to wait for the nurse practitioner, a patient care assistant can set them up for a telemedicine visit that then goes into one of our less busy clinics, and they can have a complete telemedicine. Is incredible. The ability of us to basically do the regular visit is great. And this is an area of connectivity. When we start to be able to flow this information to others, we're going to be really excited about it. Bottom line, like the rest of the people who've been presenting here, there's a ton of great ideas out there. We really are waiting, though, on better connectivity in order to really accomplish some great things for the healthcare system. Thank you very much.